Good morning. Good morning, everyone. Good morning อาจารย์สุภาวดีครับ
Good morning ค่ะ
Good morning ครับ so since some of our faculty and PhD students may have duties right now, so we're gonna start this session and also record this. So I would like to welcome all of you to another topic session for implementation science and research trends, moving evidence to practice by Professor Dr. Alicia K. Matthews from the School of Nursing, Columbia University. So Dr. Matthews is going to share us about how is the implementation science is a trend right now and how it is important to our nursing career. So please welcome Professor Dr. Alicia K. Matthews.
Good morning. It's a pleasure to be back with you, talking about such an interesting and new topic for nurse scientists. So today I will be talking about the relationship between evidence-based practice, something many nurses are familiar with, and implementation science. Discuss the goals and rationale for implementation science, and then provide an example from my work of an implementation science planning project. So first, let's ground our understanding of this work in implementation science in the literature related to evidence-based practice. We have known for, and has been a priority in nursing for more than 20 years now, about the importance of using the best evidence available combined with clinical expertise and training and patient values to establish evidence-based practice initiatives. So what are the advantages of really focusing on evidence-based practices in nursing? First, it improves patient outcomes through the provision of superior care. It maximizes providers' time and reduces costs. And then finally, adds new contribution to the science of nursing. But as many of us are most concerned, it is instrumental to improving patients' outcomes. So why has there been a focus on evidence-based practice across the health sciences, not just within nursing, but across the health sciences in general? The movement began with the identification of a really significant problem, what was defined by the Institution of Medicine as the unacceptable gap between what we know from our research and what we actually do in the care of patients. There is a significant gap between our knowledge base and our practices. So with the understanding of this significant gap, the Institute of Medicine in 2009 set a standard and goal for the year 2020 that 90% of clinical decisions will be supported by accurate, timely, and up-to-date clinical information and will reflect our best evidence that's available. But now we are 2023, 2024, and we still have a significant gap. The evidence suggests that it takes about 17 years to move from knowledge from randomized clinical trials and other types of evidence generation to uptake practice area. The literature suggests that fewer than 50% of clinical innovations ever make it into general usage. So this is important as we think about the role of innovation in clinical care for improving health outcomes, especially as we see the really global trend toward. So implementation science has emerged out of the necessity of closing that gap between what we have learned for research in terms of the best evidence and what is actually taking place in the clinical practice area. So the goal is to use implementation science to reduce the amount of time that is required to bring evidence into practice. So so far, we're learning that if implementation strategies are considered at the time of research development, we see a significant reduction in the time that it takes for evidence to reach the practice area. So those studies that are grounded in the implementation science framework are into the practice setting with 80% of those projects are in the practice setting within 3 years' time. So what do we mean when we talk about implementation science? It really is the scientific study of methods to promote the uptake of research findings and other evidence-based practices into routine practice care. It expands the model for evidence-based practice from looking at evidence, clinical expertise, and patient factors to include the key issues of implementation, examining clinical practice settings, issues related to costs and accessibility. So implementation science as it relates to evidence-based practice is really a series of action steps to put into effect the decision to change practice. And it really is the most challenging step in the evidence-based practice process. So the goals of implementation science are to, one, understand potentially the barriers and facilitators of implementing a new clinical practice strategy. Then to think about these issues prior to implementing the new evidence into a practice setting. The second is to think about new approaches to actually achieving implementation, strategies that go beyond the initial evidence that was described, that was developed for the improving health outcomes, but also to be thinking about implementation strategies. And then finally, to help us understand the differences in the relationships between development of an intervention in a more controlled research environment, and then what happens when we move to the real world setting, such as a clinical setting, when there's less, more things are happening
อ่า
and
ที่สเก็ต
and less opportunities for
สเก็ต
control.
ดูอยู่ในมือไหมจะได้บอกเป็น
Can you
วัน
please turn off your microphone, Dr. Promprakas? I'm so sorry.
อ๋ออ๋อได้คือหนูจะให้พี่จอยเซ็นนะ
อาจารย์ครับ
อืม
อาจารย์รบกวนปิดไมโครโฟนด้วยครับผมขอบคุณครับ
So implementations sciences help to inform 3 different areas. One is when to discontinue a clinical practice. It helps us to identify those strategies that, although they may be based on evidence and from the research environment, are not performing well in the clinical practice area. The second is to identify what are those factors that are interfering with the uptake of new evidence in a clinical setting. And then finally, approaches that maximize the uptake and adoption of new evidence. So there are these 3 goals: discontinuation, facilitating uptake, and understanding barriers and facilitators in the clinical practice setting. So when we think about this relationship between evidence-based practice and implementation science, it's a relationship between innovation, effective innovations related to practice, effective strategies for translating these strategies to the clinical practice setting. Third is to understand the clinical context. That is what implementation science helps us to do, to explore the environmental and the clinical context in which an intervention will take place. And then finally, understanding each of these three dynamics helps us to have the best evidence to improve patient outcomes. So many of us, our most use of implementation strategies will be thinking about what are the factors that are interfering with the uptake of evidence in a clinical practice setting. Essentially is looking at how to extend beyond the simple question of whether or not we need to make a change, but what are the most effective strategies for implementing those change to ensure that the evidence is implemented in a way that is consistent with the practice guidelines, but also is implemented in a way that takes into consideration some of the needs of the clinical practice setting. Okay. So there's actually several stages of implementation, and there's a large body of research that is starting to emerge, and in particular, an area of nursing research specialization that relates to implementation science. So it shows the processes, these individuals with implementation science expertise are aimed at studying the processes for moving evidence into practice. These steps are gaining support at the clinical practice setting for the change in practice. Next, it is evaluating the infrastructure and planning to understand where potential barriers are and if there are other infrastructure needs that such as provider training or electronic modifications to electronic health records that will help us to implement the evidence. And next step is to do an initial evaluation of the implementation. How is it working? Where are the problems that we are identifying? And then finally, evaluation of the full implementation of the evidence, determining whether or not the new evidence is as effective in the clinical practice setting or the real world setting as it was in the developmental and research arenas. There have been several theoretical approaches that have emerged as it relates to implementation sciences. And the theories are related to three broad areas. The first is looking at process models. Those are help us to guide the practice. Process was to the barriers and facilitator of bringing in that practice into the setting. And then finally, implementation frameworks that help to inform the evaluation process. So process models that help to inform our planning, models that help us to understand the barriers and facilitators, and then finally for the actual full evaluation. So let's look at some of these models. One process model is related to phases. It helps us to see that the early process of planning is related to four steps. Exploration, that is identifying the need, examining fit and feasibility of the evidence-based practice into the new clinical practice setting. The second relates to installation or planning. So making sure that you have the resources and supports, the infrastructure in place to install that new evidence. The initial implementation, that is getting started, developing and evaluating information to help us improve the uptake, and then finally the evaluation of the full implementation. Okay. So this Implementation, understanding the mechanisms, is the second realm of these frameworks. One is CFIR. It is a framework for consolidated framework for implementation research, CFIR. And this model was published in 2009, and it identifies the areas in which, from the clinical setting, the factors that are associated with successful and non-successful implementation, and helps us to identify what are the issues that we need to be taking into consideration as we are understanding how to implement the new evidence in a practice area. The first is having a really strong knowledge of what are the elements of the intervention itself, the evidence and of the usefulness of the intervention, the complexity, the cost associated with the new evidence. Next is to understand the inner setting, that is characteristics of the clinic itself that may inform the uptake. So structural characteristics, communication, and the implementation climate. What do I mean when I say implementation climate? By that, I mean the readiness of the clinic leadership and staff to establish a new practice. Some practice settings are quite conservative and have difficulty with implementing and changing strategies. Those because of concerns, because of staffing issues, and low resources. So those are the type of clinics that will often be significantly delayed in the uptake of a new evidence, or those that are actually practicing clinical practices that are out of date. The third area that we look at when we're considering the factors that help us to implement a new evidence into practice is the outer setting. That is understanding patient needs and preferences. The next is understanding the staff, and the staff leadership, and then finally some of the implementation processes. So that's the CFIR model. The Proctor model helps us to further understand the environment, that the clinical environment in which the research will be implemented. And it's similar to CFIR, but it focuses on slightly different issues. It works to understand the context of what it is that we're trying to implement, how, what are our specific implementation strategies that we'll be using, what are the implementation outcomes, and these key implementation outcomes are feasibility, fidelity, penetration, acceptability, sustainability, uptake, and cost, and then patient-related outcomes, both proximal and distal. So proximal outcomes will be related to increased efficiency and safety of our clinical procedures and quality of our clinical procedures, which then ultimately improve our health outcomes, patient health outcomes. So this is one widely used framework for understanding the processes for implementation. And then finally, the outcomes, evaluating the outcomes of the impact of our implementation approaches. One is PEPFAR. It looks at monitoring 3 types of outcomes. The short-term evaluation of the uptake of the intervention itself, the impact on the system, and then impact on the patient as well, and health outcomes. So those are 3 key frameworks that have been used, and there are many more that have been established. But what we have been really learning from these conceptual frameworks related to implementation is that the setting is as important to understand as the components of the evidence-based practice itself. So there are a number of system or setting-based considerations that are vitally important to understanding and to increasing the success of implementing a new evidence-based practice. And these setting-based issues relates to one, the organizational culture, again, readiness for change. The second is relates to leadership, whether or not the leadership has the capacity to bring about the change or facilitate and provide permission for the changes. How are the communication systems within that organization that helps to disseminate the new information about the change in practice, the training and the training of all staff and providers that are associated with the delivery of the new change, identifying whether or not there are resources that are needed beyond what is currently in place in the setting in order to successfully implement it. And then again, really focusing on evaluation and monitoring so that we can refine our processes to ensure effective implementation in the setting. A lot of this success at the clinic level requires having what we call champions in place at the clinical practice setting. That means an individual or a team whose primary responsibilities are aimed at the successful implementation of this evidence-based practice. Now, the champions' roles are to help provide leadership, to help move and overcome barriers at the leadership as well as the practice setting, and then to help to motivate and support the providers and staff as they are learning the processes of the new evidence-based practices. So implementation has the goal of both bringing into practice, into awareness and practice the new evidence, but also the removal and the discarding of what was previously done. What happens when we are in a healthcare system that has been focused on using one practice and then now we've implementing a new practice? Sometimes we can have a mixture of clinicians who are still holding on to the old standards and which can have a negative impact on the patient outcomes, because again, we are implementing the new evidence because it's been identified to be superior to what we've done before. But many people will be hesitant to make this change. And so this is one of the key issues that needs to be consistently monitored, that each of the faculty, the staff, and the providers have the knowledge, incentives, and are being monitored for and given feedback about their performance with the new evidence. So the key point here is that just because a new innovation is introduced to the staff to a new clinical setting, it does not mean that it will be adopted. It does not mean that it will be adopted correctly. And there, in very high likelihood, there are a number of clinic level factors that need to be addressed in order to increase the successful uptake of that new evidence. Okay. So when we're looking at the combination of thinking about implementation as we are developing our new evidence-based practices, we have a number of guidelines that have been developed that help us to really think about these processes. There are 3 types of implementation designs. When I'm referring to implementation designs, it is really thinking about the combined research that's looking at the evidence as well as strategies for moving that evidence to practice simultaneously. And it's called hybrid designs. We're looking at the effectiveness of a new intervention as well as implementation approaches. The three types of designs are related to how much is known already about the clinical intervention or the implementation strategies. So the first design is called Hybrid Design 1. It tests the effectiveness of the clinical intervention, right? It's establishing the evidence of a new clinical intervention on patient outcomes while gathering information that might have implications for implementation. So we might, for the first time, be testing a clinic-based diabetes self-management intervention. So it's testing a new intervention to gain evidence to understand, does this new self-management approach improve patient outcomes? In this model, we're primarily interested in understanding the evidence for the intervention, but along the course of the way, we're also gathering information either by observation or interviews with leadership or staff that help us to understand what were some of the difficulties that the clinic experienced or the providers experienced in actually implementing or testing this evidence for self-management. That information is collected at the same time or shortly after the actual randomized clinical trial to be used in the future when we consider movement to the clinical practice setting. That's implementation hybrid design 1. Hybrid design 2 is simultaneously testing both the effectiveness of the intervention and specific implementation strategies. So now we're looking both at the evidence for self-management and the new implementation strategy for helping to build that into clinical practice at the same time. So we are simultaneously evaluating intervention approaches such as self-management, teaching self-management to nurses and patients, and also the implementation strategies of using the electronic, for example, using the electronic health records to evaluate the success of the teaching and evidence that the patient is indeed adhering to the self-management approaches. So dual testing, clinical and implementation strategies. And the third model is we use when we have already the science and the evidence for an intervention. Many studies have established not only the efficacy, right, the ability to change a health behavior, but the effectiveness, meaning that that intervention has been replicated in many settings, including the practice setting. But we're finding issues and barriers to actual uptake in the majority of clinical practice. Now we're not so much evaluating the evidence-based strategy. We know that that works. What we are looking at instead is approaches, implementation approaches that are helping to guide the embedding of that new evidence into the clinical practice setting. The most common at this point is hybrid type 3, where we have known strategies that are effective, but are trying to address the delay in uptake into the clinical practice setting. Okay. I'll stop here to see if there are any questions. Feel free to ask the question in the chat box or to unmute and ask it in Thai language or English. Either is fine. Okay. If there are no questions at this point, I'll keep going. So when we are evaluating our implementation outcomes, there are 3 levels of outcomes that we're evaluating. Remember, one of the key aspects of implementation approaches is to actually evaluate the outcomes from our implementation strategies. And we evaluate outcomes at 3 different levels. The first is looking at clinical outcomes at the level of the patient, the provider, and the system. So clinical specific outcomes at the patient level include actual changes in physiological measures or evidence from disease management, changes in patient knowledge or quality of life or satisfaction with care. Those are all appropriate clinical outcomes at the patient level. Appropriate clinical outcomes at the provider level are related to provider satisfaction, safety, as well as cost associated with the new evidence. And then at the system level, we can evaluate differences in length of stay from the old strategy to the new evidence-based practice, issues related to patient morbidity and mortality, and then system level questions related to patient safety. So we can look at and should be evaluating clinical outcomes at the patient, provider, and system level.
เขาเซ็นให้นักข่าวพอเอกบอก
Please turn off your microphone.
ไม่รู้ถามอาจารย์ไม่ดีพี่ไม่ต้องใช้
Hello. Please turn off your microphone ด้วยครับ
Okay. Other non-clinical outcomes, again, we can look at issues with patient understanding and literacy related to health and wellness, treatment adherence, which we know is directly correlated with patient outcomes, patient knowledge and satisfaction with care. Each of these non-clinical outcomes are the proximal to improving patient outcomes. The same thing with the provider and system level factors. These non-clinical outcomes, again, are very proximal to improving patient, provider, and system level outcomes. What are the key outcomes that we should be thinking about when we first are looking at implementation? The implementation outcomes that we're looking at relate to acceptability of the new intervention by patients and staff. That's a key implementation evaluation outcome. Adoption means what percentage of the providers have adopted the new evidence-based practice. Or if you have multiple systems, multiple clinics under the same system, what percentage of the clinics have adopted the new strategy? Also, measures of how the providers view whether or not they view it as appropriate for their level of training and their clinical practice setting, as well as resources. Then we look at issues related cost, feasibility, and again, there are established measures of provider acceptability, appropriateness, adoption, feasibility, and fidelity. Level of penetration, and then key to implementation success is sustainability. Once the researcher or the implementation team leaves, is the infrastructure in place so that the new evidence can be sustained in the clinical practice setting without intervention from the research team. Those are the primary implementation outcomes as it relates to implementation science itself. Then our next step is to look at clinical and service outcomes, such as, again, patient-centered outcomes, safety, and then finally, patient outcomes, morbidity, mortality, patient health status, and population and quality of life at the population level of your clinic. So again, you can see how there are multiple levels of evaluation that are appropriate for implementation science strategies and to determine how effective your implementation approaches are, as well as how effective the new evidence is, the new intervention approaches are with your patient population. Now, let me give you an example of an implementation science project, the preparatory phases of it. My team and I have been funded by the National Institutes of Health to study the question of the high rates of smoking among low-income patients. In the United States, we have what we call safety net clinics or safety net centers. These centers are funded by the government, and their objective is to provide high quality care for low income patients who have limited health insurance coverage or limited income to pay for health insurance. This is a way that we're trying to ensure that all patients, regardless of income level and insurance status, have access to high quality care. But what we find in these clinical practice settings is that, as we know, low income is also associated with low education, high rates of health risk behaviors, and very low rates of health promotion activities. This means that the patients who come to our clinics have high rates of chronic diseases, including diabetes, hypertension, cardiovascular disease, a number of mental health and substance abuse issues as well. We also see a high number of health risk behaviors that are associated with these chronic diseases, such as heavy rates of drinking and smoking. In many cases, especially with tobacco use, we have strong evidence for clinic and provider delivered smoking cessation treatments. This evidence has been in place for more than 25 years. But what we find is that there is low uptake in the clinical practice setting, even though by providers, even though it is mandated by governmental policies that all providers in safety net centers must counsel and assist all their smoking patients that smoke with receiving treatment. But the literature shows that less than 50% of patients who smoke are offered treatment by their providers. And this is even worse for patients who have language barriers, such as immigrant populations, or who belong to racial and ethnic minority groups who continue to experience discrimination by healthcare providers. So our study was funded to look at implementation of overcoming implementation barriers and to evaluate a new implementation approach for increasing the consistent delivery of smoking cessation treatments among low-income patients in a safety net center. Prior to implementing this study, we needed to do a lot of preparatory work. As you recall, many of the implementation frameworks highlight the important issues of understanding context, including the patient population, the providers, as well as the acceptability of the implementation approach or the evidence-based clinical intervention. So first thing that we did, we really started at understanding the health risk behavior in our population. We know that smoking is still a significant health concern for the the global community. In the United States, in the United States, 12% of all adults are current smoker. This is the lowest that it has been since the government started to address smoking in the general literature. But what we find is that smoking remains much higher among low-income communities, and especially racial ethnic minorities who are underserved in the healthcare setting. Data suggests that more than 25%, 1 in 4 low-income patients will be current smokers. That compares to 10%, just a little over 10% of patients who have the highest rates of income. As I was mentioning, we in the United States, we have what's called federally qualified healthcare centers, which is our safety net centers funded by the government. Studies in our group and others have found that 25% of all these patients, and oftentimes higher, are current smokers. Even though providers in FQ8Cs, federally qualified healthcare centers, even though these providers are mandated to provide treatments, consistent delivery is low. And then this is even though we have very strong evidence, one clinical practice guidelines, evidence-based, is AAR. This is a clinic-based tobacco treatment intervention that's meant to be delivered by doctors and nurses in the practice setting. The first step is to ask all patients about tobacco use, for the providers to advise them to quit smoking. And among those patients who are interested in quitting smoking, referring them to treatments, either outside treatments, a smoking cessation clinic within the healthcare system, or to provide treatment by the provider, such as nicotine replacement therapies. We see good adherence to asking patients and documenting their smoking status, but that's where it stops. The majority of patients are asked about their smoking status, and that's documented in the electronic health record. But far fewer patients are advised to quit, and among those who are advised, even a smaller percentage are referred to treatment. One innovative strategy for helping to deliver this evidence-based approach is to use the patient portal. This is the innovation that my group has developed and is currently evaluating. So one of the primary barriers to the consistent delivery of AAR is provider time and training. As I mentioned, many of the patients who come to safety net centers have 2 to 3 chronic disorders, and patients and providers say that they do not have time to address smoking with their patients because of needing to manage the chronic disease. We are evaluating the use of the patient portal as a means for delivering AAR. So what is a patient portal? Patient portals are secure websites that are linked to the electronic health record that allow patients to see aspects of their clinical chart. They can see their appointments, their diagnoses, the medications, and they can communicate via email and secure messaging to their providers. In the United States, 93% of all hospitals and clinical practice settings now offer the patient portal. So and 4 years ago, we saw that the trend for offering and using patient portals was significantly increasing. 60% of providers were offering their patients to use the patient portal, and about 40% of all patients were enrolling and accessing the patient portal. Patient portals are available using computers and smartphones, which we know that the vast majority of adults, now even older adults, have access to a smartphone. So because of that, we're starting to evaluate, sorry, having trouble. Because of that, we're starting to evaluate whether or not we can implement health promotion strategies using the patient portal. Evidence so far suggests that patients who use the portal to monitor their medications, to communicate with their providers, and to be able to see their lab results, portal use is associated with improved quality of care, enhancing patient knowledge, self-efficacy, and decision-making, improve medication adherence, as well as preventive services. So the evidence is emerging to be very strong in terms of the benefits of healthcare systems utilizing patient portals, as well as increasing patient awareness and uptake of patient portals. Increasingly, we are seeing patient portals are being used to deliver health promotion interventions, such as my group on smoking cessation. But there are challenges. There's so far has been a limited number of patients who are enrolled in the portal. There are potentially differences in the uptake and use of the patient portal based on socioeconomic status. And there may be differences in the accuracy of smoking data in the electronic health record. So the purpose of our study was to determine the effectiveness of delivering AAR, ask, advise, refer, smoking cessation intervention via the electronic health record that is linked to the patient portal. So this is a hybrid type 3 design. If you recall, the type 3 design is most appropriate when we have strong evidence for an intervention, but that intervention is not being consistently used in the clinical practice setting. So the goal of the study is to evaluate a new implementation process. That is a new way of delivering that evidence-based approach that aims to increase uptake and adoption. So our implementation study had 3 primary goals. Was to determine, one, is our strategy more effective than standard of care in terms of increasing the reach of the patient portal and linking patients to smoking cessation, determining the adoption, uptake, and fidelity of implementing the new approach and via the patient portal, and then looking at questions related to sustainability. So our first steps were to look at issues related to process. Again, guiding our understanding of how to translate a new practice, a new implementation strategy into practice. So our first goal was exploration. Exploration meant understanding as much as we could about what were the barriers to implementing a smoking cessation, what were provider and patients' attitudes about smoking cessation, the use of the patient portal, and the use of the patient portal to deliver smoking cessation treatments. And also trying to understand what are potential barriers and facilitators at the clinical practice level as it relates to the electronic health record and our ability to use the infrastructure of the patient portal to deliver this intervention. So there are 4 milestones when we were looking at process. The first was listening, so defining the change, doing a needs assessment, listening, getting leadership support, thinking about and selecting and modifying where necessary our implementation strategy. And again, our implementation strategy here is the use of the patient portal, and then to evaluate our preliminary strategies. So first was to establish the partner. We partnered with Miles Square Health Center, which is a safety net center that's associated with the University of Illinois at Chicago. This safety net center, as I said, was primarily responsible for taking care of low-income Hispanic and African American patients who live in close proximity to UIC. When we were defining the change that needed to happen at the practice level, we first were looking at evaluating how consistently is smoking being documented in the electronic health record. We needed to evaluate whether or not there was additional education and training related to offering smoking cessation that was needed, how to support offering of AAR to all patients, and then establishing this referral strategy to smoking cessation treatments. Our third was to use findings to listen to both patients and providers to understand what is the context with the patients and providers as it relates to interest in quitting among patients. What we found here by looking at using in-depth interviews is that the majority of patients were interested in quitting, but providers underestimated that interest. So we found that 70% of patients said they were interested in quitting and interested in receiving help from their providers, but the providers estimated that only 10 to 20% of patients were interested in quitting. And so as a consequence, they weren't even bothering to talk to those patients because of their assumptions that no interest. So right away, we understood that there was differences in, there were issues related to the provider's attitude that needed to be addressed. The second thing that we looked at was what was actually happening among providers as it relates to advising patients to quit. Excuse me. When we talked to patients, they said, yeah, majority of the patients, when they come to the clinic, someone asks them about their smoking, and that gets documented. And many patients also say that their providers advise them to quit smoking. That's the second phase of ask, advise, and refer. But where the key problem is referring patients or offering them help. Fewer than 30% of the patients that we interviewed said that the providers offered them actual treatment. And so they were frustrated because they were interested in quitting. They were receiving advice to quit, but no support and treatment for quitting. The providers, when we interviewed them, they confirmed that they said they felt very confident in asking patients if they smoke and advising them very briefly, you should stop smoking. But where their confidence in training was much lower was in their ability to actually advise and offer patient treatment. And so they admitted that very rarely were they offering patients treatment. And so, again, we were seeing that disconnect between the evidence-based approach and what was happening by providers. The third thing that we were interested in is that because the providers lack training and are overburdened with managing chronic diseases, we were looking to see whether or not the state tobacco quit line, which is a government-funded free smoking cessation treatment, could be used to help support providers in offering care. So we also asked patients and providers about their attitudes about the state tobacco quit line. Many patients were aware of the quit line, but their engagement was low. Providers also said that they were aware of the quit line, but again, that it was not common for them to refer their patients to the quit line. So our first goal was to listen, understand the context around the intervention and our approaches. The next thing that we did was that we worked with the leadership at our healthcare center to get support for the new strategies for offering treatment advice and referring patients to care. We met with the leadership at the healthcare setting. That included the medical director, the healthcare staff, and the IT staff to talk with them about the importance of smoking cessation, what were the available resources, and which of their staff would be the champions or would collaborate with our team in trying to implement this work. We found that the leadership was strongly in support of this because they knew that tobacco was a big problem within their patients, that they were mandated to provide treatments, but they were not doing it at the effective levels. So our approach was in alignment with their goals, and so we had good support from the practice setting, which was key. So our next approach was to think about our new implementation strategy. Our implementation strategies were related to the patient portal, linkage to the Illinois quit line, and the use of patient navigators for helping patients to assist them with addressing barriers either to accessing the patient portal or receiving linkages to the quit line. So the first thing that we asked was we used the electronic record to identify what percentage of patients currently smoke and what percentage of patients had smoking status documented. The next thing that we did was qualitative interviews with patient and providers. Then thirdly, we were evaluating our strategies for patient portal uptake and enrollment, and then pilot testing. We looked very carefully for patient and provider attitudes using qualitative interviewings about what patients knew about the patient portal and what they saw as the benefits. Many patients, about half of the patients were aware of the patient portal, and those patients that used the portal said that the benefits were for them were able to check their labs, to monitor their health, to schedule appointments, to see their medications, and to communicate with their doctors. And these are the ones that have, these are the benefits that have been described in the literature and were strongly endorsed by our patients as well. So patients who were using the portal identified a number of strong benefits. However, we also identified some barriers, patient level barriers to patient portal enrollment or use. So not all patients were aware of the patient portal, even though the university had done a big clinic campaign to advertise the patient portal. So many patients said that they lacked awareness of the portal itself. Other patients may have said, well, I'm aware of it, but I don't know what it is. I don't know how it benefits me. I don't know how to enroll. Other patients were saying that I need help because I don't have a whole lot of computer skills, or I really struggle with this literacy information. So we identified awareness, education, and health literacy and computer literacy as barriers. So we received recommendations from patients to help better increase access to what we were planning to use as our key implementation strategy. So in order for us to move forward with our implementation strategy, patient portals, we needed to do a preliminary study to address barriers to the patient portal. So the patients in the qualitative interviews were very clear about what they needed. They wanted education materials to increase awareness. They wanted staff support for enrollment. They wanted materials that helped them to understand the computer and how to enroll. And they wanted assistance with navigating the patient portal. We then developed a pilot study to evaluate the use of lay community health workers or patient navigators to increase patient portal enrollment. So again, even though we're interested in the evidence-based approach of smoking cessation, remember, hybrid design 3 is focused on improving and understanding what is needed for the successful use of the implementation strategy. And that again is patient portals. So some of our preliminary exploratory work showed us that we needed to do an intervention to increase patient awareness and enrollment in the patient portal in order for us to be able to successfully use the portal to deliver smoking cessation treatment. So patient navigation is an evidence-based approach for increasing healthcare access to low-income populations, because patient navigators are trained to how to communicate effectively with patients, to educate them on issues related to health literacy, and to help them directly overcome barriers to accessing care. So patient navigators were trained and hired to specifically support patients in enrolling. So this pilot study aimed to evaluate the benefits of patient navigation for enrolling patients into patient portal called the MyChart. We used 3 clinics in our FQ8 settings, safety net clinics. The intervention lasted 8 months. We trained patient navigators first on general navigation skills, the use of the electronic health record, and specifically how to enroll patients into MyChart, which is the patient portal. They In the clinic, they offered help with enrollment. They provided patients with educational materials, and they called patients after their appointment to evaluate whether or not there were any barriers to usage. So we developed a specific protocol to increase uptake of the portal. Here is an example of our education materials. We developed them in collaboration with patients, providers, as well as experts with expertise in low health literacy. So these were new materials that were developed that described what the benefits of the portal were, how to access it, and then how to get started. What we found in that 8-month period of time, that our navigators were able to talk to over 2,000 patients who were unenrolled in the patient portal. 42% of them said no to assistance. So 42 said no, we're not interested. And the patient navigators helped us to identify the reasons, the barriers to enrollment that we will be able to address in a future study. One of the main issues that they were either already enrolled, were not tech savvy, or didn't have access to the smartphone or the internet. Those were the key barriers. The good news was nearly 60%, 58% said yes, and they were assisted with the enrollment. We found that of those patients that were interested, we were able to activate accounts with over 700 of those. Among patients who were already enrolled, we helped them to re-enroll or to address barriers such as loss of passwords. So that was very effective. We did a pre-post evaluation using the electronic health records, and we saw that there was a statistically significant increase in patient portal enrollment in the 3 clinics in which we had our patient navigators, and that the patient enrollment was highest among African American and Latino population, who are typically have the highest rates of smoking and health inequalities. So this approach was very promising, and we have published the results of this pilot intervention. We are now going in with a separate study to do a randomized clinical trial evaluating this model of increasing patient portal enrollment. Okay, so our results were very promising when we were evaluating our implementation strategies, the availability of it. The next steps are to evaluate, as I was mentioning, the reach of the patient portal. Again, of those smokers who are enrolled in the patient portal, which we are continuing to enroll patients, of those patients that are identified as smoking in the electronic health record and who are also enrolled in the patient portal, which percent of them receive or open a message from their provider advising them to make a quit attempt? That is our first implementation question, and it relates to reach. So our goal is to be able to at least reach 70% of all smokers in our healthcare system with a message from their provider advising them to quit smoking. That is our evaluation of reach. The second one, implementation outcome, relates to adoption and uptake. Again, what percentage of providers were continuing to document smoking status? and enroll patients into the patient portal. We're also looking at the question of our ability to use the electronic health record to link patients with treatment. And so there are a number, it's a very complicated design, implementation design, but again, we're looking at the type of messages that are sent into the portal and whether the type of message has any impact on whether the message was seen and whether or not patients opted in to be referred to the electronic health record. And then those patients who are not reached, we have a second approach in which we are using patient navigators to contact patients directly. So all this work takes place, this intervention takes place completely outside of the clinical appointment. And again, its main focus is on a population base, trying to reach all the patients who are documented as smoking to receive a message and advice to quit and an ability to be linked to the electronic health record. Okay, that's an example of the exploratory process of prior to conducting an implementation science study. There are a number of research tools that are available around implementation science that really provide more in-depth information about the theories, frameworks, and models, and also very practical advice about how to implement and evaluate implementation strategy type of outcomes, whether it's related to hybrid type 1, where you're looking at the evidence and some preliminary work related to implementation, or implementation type hybrid type 2, where you're simultaneously looking at the evidence of the intervention and implementation strategies. Or if you're looking at hybrid type 3, such as the example that I provided, which had established evidence that was not being delivered, but instead we were looking at our implementation strategy.
Can you please turn off the microphone? โทษทีครับรบกวนปิดไมโครโฟนด้วยครับขอบคุณครับ
Okay. So in summary, and we have plenty of time to answer questions, evidence-based practice is central to high-quality nursing care. But as we described in the first part of this presentation, there is a significant delay, 17 years, between the identification of a new strategy for improving health risk and patient outcomes to actually adopting in the evidence, in the clinical practice. Further, evidence shows that about 50% of new evidence does not make it to the practice setting, which has important implications for our ability to provide the most evidence-informed care. But the preliminary research shows that if evident interventions are guided by implementation science, and the implementation science approaches are used to establishing best practices for helping the clinic to uptake or implement or adopt the process, that we have 80% of interventions being delivered in the setting within 3 years. So evidence-based practice is critical to patient care. There's a significant delay in transferring evidence to practice, and implementation science and implementation research projects help us to reduce those gaps. So at this point, we have time for any questions or comments that you might have. I'll try to stop sharing so I can see you.
So they have some question in chat box. as we can see, like the first one, is it necessary to have 3 levels of outcomes, or it depends on the model of the implementation research? That is the first question.
Thank you for that. That's an excellent question. Yes. Ultimately, the goal is to have evaluation outcomes at all 3 levels. However, as with my project, we will look at the short-term outcomes related to uptake, reach, and adoption. Then we will look at acceptability by among the patients, staff, and the healthcare system. Then we start to look at more distal outcomes and future studies and evaluations. How does this new practice impact our patient outcomes over time, and also our system level outcomes over time, such as morbidity, mortality, patient safety, and costs? So the answer is yes. Ultimately, you want to look at all 3 levels, but mostly short-term outcomes are the initial evaluation. Reach, acceptability, sustainability, immediate outcomes, adoption and sustainability, and then starting to look at patient and system outcomes. So thank you for that question.
Still have another question from Dr. Rangsiman. What types of research questions to conduct the implementation research?
Any area in which we have established clinical guidelines in which we're seeing that there is insufficient adoption and consistent delivery among the clinical practice staff. So what is an example? How about the issue of HPV vaccination among adolescents? This is, and now young adults. This is an established practice guideline, but we see that uptake in many clinic settings is low. HPV vaccination is a primary prevention for the development of cervical cancer and other sexually transmitted infections that increase risk for HIV in the future. We know that vaccination among adolescents and young adults is critically important, but we see barriers among practitioners as well as patients in terms of uptake. That would be an important example of an implementation strategy. The evidence is strong for the intervention, vaccination on clinical outcomes, but we're seeing poor uptake among practitioners and patients. This is a prime example for us to conduct a hybrid type 3 study when we start to implement, better understand what are the barriers for the staff in terms of consistently monitoring vaccination eligibility and offering it among patients. And what are some of the barriers among the patients that is related to low uptake? Because we have evidence-based practice is related to the evidence, the patient preferences, barriers, the provider knowledge, and the implementation strategy. So we need to understand what's happening with the providers, the patient, and what's also happening in the clinical practice level. We might need to do something like as simple as using the electronic health records to flag or to signal to the provider, this patient is age eligible for HPV vaccination. Please remember to advise and offer the vaccination to patients today at their next clinic visit. That would be an example of an implementation strategy, the use of the electronic health record to notify the provider as that this patient is eligible. Because we have to monitor many different kind of vaccinations. And so some things are top of mind, but others fall, providers have more difficulty remembering some of them. And so if we want to specifically increase the uptake of HPV, we could do an implementation strategy such as notifying patient providers when a patient is coming to the clinic today and they should be vaccinated or offered vaccination. That would be, so the same thing can be true with medication adherence. The same thing could be true with lifestyle modification after cardiovascular disease event. So any area in which you're seeing low uptake in an evidence-based approach in your practice setting would be appropriate for an implementation science research question. How do you identify those areas? Typically, quality assurance evaluations are used to evaluate how consistently are we meeting our practice guidelines, those guidelines that are falling below the acceptable levels, 80 to 100%. Those are good targets for implementation research, especially if it's quite low, less than 50%. You have questions about that?
Okay, we still have one more question, but if like those audiences want to share or have other questions, we still have time to do that. Please leave your message in the chat box or turn on the microphone and discuss together. So right now, so far, we have another question in the chat box. What phenomena may appropriate with the implementation research?
So it's very, very similar to the previous question. And again, based on two things, the nursing discipline has established new clinical guidelines, and there's going to be a change from what has been done before to what is being recommended and mandated now. That is a prime example of when we need to evaluate implementation strategies, because we know that the change in practice will not happen automatically without a clear understanding of what it is that's being asked of providers. Are the providers, do they need additional training, or is there additional infrastructure or supports that are needed to migrate from the old approach to consistent and high level adherence to the new strategy? So that's the first example, when there's a new recommendation for clinical practice. The second is when you do a quality assurance evaluation of existing evidence-based guidelines, whether that's related to cancer, cardiovascular disease, diabetes, pediatrics, adult, gerontology, all area of practice in which we have established clinical guidelines should be periodically evaluated to determine what level of adherence do we have among our providers through this clinical practice guidelines. Any area in which there is insufficient adherence or low consistent adoption or sustainability is an area in which you should consider an implementation science evaluation and intervention to increase the adoption and sustainability of that new guideline. Those are the two contexts: new knowledge, new practice guidelines. Secondly, poor adherence among the practitioners or the practice setting with an established practice guideline.
Thank you so much. We still have other question. I think this topic is quite like interesting because it's become like a something that news and quite like a need more explanation. Other questions are how does implementation research differ from research utilization and continuous quality improvement? And is it cost effective to conduct research to evaluate the outcome of the research that has already been done?
Mhm. So what I'll start with the latter question. When we're looking at cost effectiveness, we know that interventions that have been established, they have the evidence for them, but we may see that the translation from the research environment to the clinical environment has some difficulties with actually improving the evidence, the outcomes, because of problems with implementation or fidelity, and that it may, in some cases, in the short term, increase costs because you may need to add an additional specialized provider. You may need to pay for an infrastructure development. Or you may need to pay for short-term evaluation team to clearly give you the information about what's happening in terms of overall cost at your location. That preliminary information can give you the evidence whether or not it's it's feasible for you to move forward with implementing that specific intervention. So the cost effectiveness is always important with any intervention. Cost, but it's balanced by the short-term cost of more provider support and infrastructure development with the long-term savings because of better patient outcomes. So if we're able to demonstrate that the improved patient outcomes offset the short-term cost of additional providers or infrastructure, then it is shown to be important. So many studies are embedding cost effectiveness. We have a cost effectiveness endpoint in our study as well. Whether the cost, short-term costs associated with patient navigation, building the infrastructure in the electronic health record to send these messages to the patients and then to link them to the state tobacco quit line. Compared to the cost of smoking related diseases or the cost of paying providers to deliver this intervention to every single patient in person. So those are where the cost effectiveness questions come into place. Now, how is it different from quality improvement? Quality improvement says, are you doing it? Right? And the strategies that we're using to ensure to bring in the new practice, are they working? So quality assurance really just tells us the thing that we're trying right now, is it working, yes or no? Implementation science says, why might that strategy work? What are the barriers to that strategy? And how can you increase infrastructure and support within the practice setting to increase the likelihood that that intervention will be delivered in a way that it was meant to be delivered and continues to have benefits for the practice outcomes. So quality assurance says, are we doing what we're supposed to be doing? And is it improving our patient outcomes? But implementation science goes the further step of saying, how can we ensure our quality insurance approaches or interventions? Because quality assurance is saying, is it working? Implementation says we can do these things to ensure that it works or to identify barriers to why it isn't working, or to establish new strategies for how to increase the adherence by providers to that new strategy. Okay, so give me an example. Charting. It was in the past, all nurses need to chart after seeing every single patient. The initial practice was to take the note, and then that needed to get scanned and go into the documents. Then the nurses were to take notes, transfer those notes at a centralized computer station, enter those later. So that was an inefficient one. So then they looked at to have nurses have traveling computers so that they can in real time enter their notes. So quality assurance is asking, after each patient visit, has charting been appropriately done by the nurse? That's quality assurance. Implementation science is to identify why is charting not being done and how to reduce the time and increase the efficiency of charting by using mobile approaches. So that would be an example of a quality assurance versus an implementation study question. Does that make sense?
Yes, but they refer to research utilization. Is something that you want to add up more? Like, is it different from
Can you please clarify what you mean by research implementation?
research utilization?
So research utilization, what does that mean? Is it establishing the evidence for an intervention like a randomized clinical trial? That is, so randomized clinical trials or quasi-experimental designs or pragmatic designs, those are appropriate for establishing the evidence. The evidence for the smoking cessation intervention, the evidence for the mental health intervention, the evidence for self-management. Research strategies establish the evidence. Implementation strategies help to translate the evidence to the clinical practice setting. Those are the distinction. Quality assurance is the long-term evaluation of adherence to the clinical practice guidelines and the cost and improvements in patient outcomes. So evidence, traditional research design, implementation, transfer to the clinical setting is implementation science. Fidelity and effectiveness over time and consistent delivery is quality assurance.
We still have another questions asking about what are difference between PDCA, Plan Do Check Act, or R&D research and evaluation research.
I don't know what the acronym stand for.
PDCA is like a Plan Do Check Act. Is the way that we used for quality assurance, like a Plan Do Check Act, like a circle. Okay.
All right.
Yes.
So that's a process measure for implementing or putting into place an evidence guideline. That evidence guideline is then monitored over time to see whether or not there's fidelity and it's working. That's the way of helping. It's a process evaluation. As we were talking about implementation science, implementation also has process models that are very similar to what you just described in the quality assurance literature. Where the difference is that some of our implementation science models instruct us to understand in advance what needs to be in place to ensure the likelihood that intervention can be successfully put into place, and to develop strategies for improving the implementation. So we see, let me give you another example. We see from the research that patient portals are associated with improved patient communication, health promotion, patient outcomes. That's the evidence based on traditional research evidence. Hospitals are now advocating and offering access to the patient portal. That is offering it in the clinical practice setting. However, 38% of patients are aware of, nationally are aware of and using the patient portal. So a quality assurance question is, are patients being provided with information about the portal? And is the portal consistently available? And are patients using the portal? Those are quality assurance, and that's descriptive information. However, quality assurance doesn't historically tell us what are the barriers and how to overcome the barriers to patient portal enrollment. Our implementation study is systematically evaluated what were the barriers and facilitators. We developed a patient navigator intervention to specifically test the strategy to improve uptake of patient portal. And now we're systematically evaluating it in the clinical practice setting. Afterwards, quality assurance would be evaluated again. Our patients continue, after these efforts have been put in place, are patients continuing to be, because this relates to sustainability and fidelity. Are patients continuing to be provided materials? Are providers asking them to enroll in patient portal? Is there evidence in increase in patient portal? And is there evidence that clinical practice outcomes are improving among those patients who are doing using the patient portal? My goal is, as the implementation scientist, is not to be interested in the practice outcomes or the quality assurance outcomes, but is to overcome the patient barrier to being aware of, knowing how to use, and having assistance with enrolling in the patient portal. That is the implementation strategy, and that's where I stop. Quality assurance picks up with the monitoring, fidelity, sustainability.
Okay.
And please feel free to translate any of that that might be hard to conceptualize.
Okay, but I think like they may, I think they got the
Mhm.
idea on what you want.
Mhm.
So do you have any other questions so far? I have my questions. So as I understand, maybe you may summarize that to me again. Implementation research, it seems like you try to build up the like how you apply the new guideline into the clinical setting. It's not like we create the intervention for patients and use in the clinical setting, right? It's different. You understand what I'm trying to say?
Uh-huh. The goal is not, for most implementation science studies, the goal is not related to the evidence of the new guideline, because that's been established by neuroscientists. And the government has said, here's the new policy, here are the new practice guidelines based on the evidence. But we know that it might take clinics decades to transfer from what they've been doing in the past to what the new guidelines are. Implementation science is to understand how to bridge that gap, how to introduce it into the clinical practice setting in a way that is consistent with the guidance, but takes into consideration the contextual factors. What are the resources available in the clinic? What is the skill and knowledge of the providers? And what are the additional patient needs of that clinical practice setting? Understand the context, the setting has to be really clearly understood to facilitate introduction and successful uptake of that intervention in that clinic. Implementation science bridges that gap. It tells us how to get it into place.
So it seems like, for example, if we do a research intervention quasi-experimental and we see that intervention of health literacy can help schizophrenia people to take care themselves. We get that like a quasi-experimental and the outcome is perfectly good. Like this health literacy can help to help the schizophrenia. Apply that intervention into clinic is that intervention research, right?
So let me back up just a second. Okay, I see. So the first study that would be showing health literacy intervention improves medication adherence among schizophrenic. One study, that's an efficacy study. That one study suggests that there is promise to this approach. Then that study must be replicated several times to show that it generalizes to other settings, to other, for other patient populations to be established as a guideline. It takes multiple studies showing the benefits before it becomes not just efficacious guidelines, meaning efficacious, meaning it's one study has shown benefit, but it has been established as effective. Multiple studies have been conducted that shows the same result. This approach is effective and should be used to guide clinical practice. Now, how to get that into practice setting is implementation science.
And then my last question, if we do implementation research study, it means it should different in different setting of the hospital or clinics, right?
The models are the same, process, understanding the contextual factors, and understanding and evaluating the outcomes. But we know that each setting differs in the number, the types of patients, the resources, the skills, the training, the expertise, the number of staff, the leadership's ability to incorporate new innovations. So the implementation strategies may differ from practice to practice to practice. We may say, here are the processes for how to get this into the practice. Here's how to evaluate how to translate it or transition it to the practice setting. And then the next step would be to say, here are some strategies that may help bridge the gap between clinics that have high resources versus low resources. So for example, patient navigators is a low cost, but a potentially effective strategy for bridging the gap between high resource environments when they have lots of staffing to sit down with patients and help them understand the patient portal and to get enrolled versus lower resource clinics in which there's no highly trained staff or provider that's available It doesn't look like connection.
Yeah.
Okay.
But it's ไม่เหมือน connection มัน lost
Having some technical difficulties. If you can hear me, just say, yes, I hear you.
อาจารย์ยังได้ยินบอยอยู่ไหมครับ น่าจะได้ยินเนาะแต่
ได้ยิน
ดร. แมทธิวส์
ได้ยิน
หลุด
ค่ะ
ไปอาจารย์
พี่
กำ
ได้
ลังพ
ยิน
ยายาม
แต่
เข้า
ดร
maybe
แม
you
ท
can
ธิวหลุด
come
ออกไปแล้ว
here and share if you want so and then we can wrap it up okay so you were yeah I think this word
Okay.
that's it
So you were just kind of summarizing what I was saying. So you want to finish with the summarizing that, or we lost track of what we were talking about?
I think lastly I asked the question about like once we apply the implementation research in each setting, so it means it might be different based on the context of the setting that we're trying to apply, because it might be every hospital, every setting have their own context, right? Like a different budget, different perspective, like a capacity, number of patients, all stuff. So once we apply to in each context, it might be different, but we try to make it fit with the context of that setting that we're going to use.
That's right. So implementation science helps us to understand what types of things we need to be evaluating at the clinic setting to increase the input in uptake. Implementation research
ไม่ได้ยินค่ะ ไม่ได้ยินเสียงจ้ะ
โอเคครับอาจารย์กำลังไปนะคะ
Thank you. Okay, good. I think we're back. Echo? No, okay, we're good. So implementation science provides the theories and guidelines for understanding how to successfully understand the clinical context for translating an evidence-based intervention to the clinic. It shows that implementation science frameworks help us to understand what to look for, what to evaluate to increase success. Implementation science research helps us to overcome those barriers to transferring or translating the new evidence to the clinic. So implementation science was my examples of the qualitative work that I was doing to understanding the context, making the relationships with the providers. All of those types of things are related to the frameworks guided by implementation science. My implementation research was related to the patient navigator, utilizing patient navigation to increase enrollment, and the specific use of the patient portal as an intervention delivery mechanism. Those last two, patient navigation and patient portal enrollment, and patient portal and smoking cessation delivery, that's implementation science. Both of them are aimed at increasing or overcoming barriers to the consistent delivery of an evidence-based approach. My strategies were guided by implementation frameworks that told me what I needed to look for, what I needed to document, and how I needed to evaluate.
Thank you so much. Thank you so much. I think we got a lot of information and clarification on implementation research science. Do you have any questions so far right now? Okay,
So
yeah, please.
I want, so it's interesting to me now what's happening with implementation science and nursing research. Right now, PhD level nurse scientists are establishing the evidence. D&P faculty, trained individuals are working at the clinical practice area and looking at things like quality assurance, best practices in the clinical practice setting. Implementation science, I think, is a merging of those two discipline training. Researchers who understand how to develop evidence and D&P faculty or more clinical providers who understand the clinical practice setting and how to have good organization and delivery of clinical practice. I see that's a nice merging of interdisciplinary teams and can be the focus of how we really bridge the world between PhD and D&P researchers.
That is very nice, and thank you so much, Dr. Matthews. I think the importance of the implementation research is how we can apply those clinical guidelines into the clinical setting and make it most effective, right? In
Yes.
terms of many things that we can do, like a cost and the cost, the budget, people or whatever. So I would like to say this lecture is so wonderful. Yeah, and thank you for the opportunity that you give us to learn and understand the better understand of the implementation research science. So I would like to ask everyone to turn on the camera, and then we can take a photo this for this session. So are you comfortable to turn on the camera, please?